Hello everyone, welcome back to Karan Academy. My name is Karan, and today we're going to be talking about colorectal cancers. Now, again, this is a very big topic and it's really important to know. I also realize, and I'm really annoyed by this fact, I keep saying this is a really important topic and it's really important to know about every single topic. But I promise this is one of the really important ones. I'm sure you know what colorectal cancer is, but it's the third leading cause of cancer death, predominantly affecting elderly populations between 65 to 74 years old. What are some risk factors? So elderly age, a family history, but more specifically, some hereditary syndromes affecting the small bowel are really, really important to know. So FAP, or familial adenomatous polyposis, is a huge one. It's a condition where you have a defect in the APC gene, and that results in thousands of tiny polyps developing throughout the large intestine. This has 100% risk of developing colorectal cancer by the age of 40. So all of these patients should undergo a colectomy, remove the colon, basically. You then also have hereditary non-polypoceal colorectal cancer, which is just very similar to this, but non-polypoceal. And this is called Lynch syndrome. It has a slightly different kind of a slightly different presentation. So familial adenomatous usually has cancers in the left side, hereditary, and HNPCC is on the right. HNPCC is also called Lynch syndrome and is associated with a mutation in the microsatellite, but that's not important to know. Smoking, alcohol, obesity are a risk factor for every cancer, and then specifically some inflammatory conditions affecting the gut. IBD, but ulcerative colitis more than Crohn's. Why? Because ulcerative colitis is continuous and you have a lot of inflammation and erosions at a superficial level. And this predominantly is affecting the terminal to distal part of the large bowel. And then celiac disease. Celiac disease particularly puts you at a higher risk of GI lymphomas than CRCs particularly. And then having a highly processed food diet, which doesn't sit well for me. In terms of symptoms, it often depends on the stage of disease. So I'll go through the symptoms first, and then we'll break the symptoms up into a few kind of categories. So the most common presentation is going to be that they're asymptomatic completely, right? And that's not good news for us. Abdominal discomfort, hematochezia, which is visible blood on the stools. Melena, which is occult blood or digestive blood that is presents with dark black tarry stools. Changes in bowel habits, diarrhea or constipation. And this is one of the biggest ones that my GP encountered and always investigated further. Tenesmus, or the feeling of incomplete emptying. Fecal incontinence, large bowel obstructions, and then you have symptoms of IDA, weight loss, fever, night sweat, which are common for all cancers, hepatosplenomegaly, and ascites. So let's break this up into a few categories. And here, as you can see, are the different parts of the bowel. So we have the cecum appendix, we have the ascending colon, transverse, descending, sigmoid, and the rectum. And you can develop a carcinoma anywhere along this line. Where you get a carcinoma actually has a pretty significant role in the symptoms you get. So let's talk about this. Let's start off with right-sided cancers. So cancers affecting the ileocecal region, the ascending colon. So all of them may present with general stuff, but specifically the things we look for are occult bleeding or melena, diarrhea, and appendicitis. Why do we get these? Let's go back to our picture here. Oh, no, sorry. Okay, so let's say it's this bit that's being affected, right? As we know, colorectal cancers produce a membrane that's quite friable, which means it's a high risk of bleeding. Because you still have so much of the gut to go, it is likely that any bleeding here is going to be digested by the time it comes out, which is why you get melena. You can also get appendicitis. As I mentioned, if you have a tumor here that's compressing, you can eventually occlude the appendiceal orifice, leading to a fecalith or fecal obstruction, and that can lead to appendicitis. Next, we have left-sided masses. Now, left-sided masses would present with blood streak stools, changes to bowel habits, and colicky abdominal pain due to obstruction. Now, as I mentioned, if it's on the left side, it has less of a distance to travel by the time it exits, and therefore any bleeding in this segment is unlikely going to result in melena because the blood just doesn't have enough time to be completely digested. And therefore, it typically presents with kind of stools with blood intermixed within it. Then you have rectal cancers. Rectal cancers can present with tenesmus, or the feeling of incomplete emptying, a protruding mass, frank blood on the stool, flatulence, and fecal incontinence. Now, this is because it's in the rectum itself, and rectal masses can often make a stool. So because you have something in the rectum, it creates a sensation as if you have to go, but obviously you don't, because it's a mass and you can't poop out a cancer, I think. Moving on, it's been a long day. So with metastatic disease, depending on where it has metastasized to, it can present differently. With mets to the liver, you can have hepatosplenomegaly, right upper quadrant pain, and jaundice. If it metastasizes to the lungs, you can have dyspnea, hemoptysis, and a chronic cough. And then mets to the peritoneum can have ascites, abdominal distension, and bowel obstructions, particularly obstructions of the large bowel. And we talk about bowel obstructions in our lecture on bowel obstructions. Okay, in terms of GI bleeding, we have a complete lecture dedicated to an approach to GI bleeding, but I just thought I'd mention this here. The difference between upper and lower GI bleedings are quite important to be able to identify. And here are the important causes of upper and lower GI bleedings. I won't be going through this extensively right now, but since one of the differentials, since one of the presentations of a CRC is hematochezia, it's important to be able to be aware of the different types. And then again, we have some features of overt GI bleeding, and that can be hematemesis, typically which is vomiting blood, melena, and hematochezia. And you can read through these. It's a diagram taken. So I think this is a diagram taken from Ambos, which does a really good summary of the different types of GI bleeds. And similarly, he is kind of a clinical picture on how different bleeds may present depending on where exactly along the GI tract the bleeding is. And again, this is also taken from Ambos. Now, when we stage and investigate colorectal cancers a bit further, as with most cancers, CRCs follow a process of firstly dysplastic change, polyps, and then carcinomas in situ, and then finally metastatic disease. We can use the TNM system of classification, so for tumor, nodes, or lymph nodes with metastatic spread, but there's also the Duke system, which is, I think, very important to know at your year level. The TX number, so T1, 2, 3, 4A, 4B, refers to the degree of invasion of the tumor. So I've covered this specifically. N and M are relatively easy to understand. So T1 is confined to the submucosa, T2 to the muscularis propria, and as you can see here, I've just got a diagram of those, of each one of those. T3 is subserosa, and then T4 indicates spread. So if it's to the visceral peritoneum, that's going to be T4A. If it's to adjacent tissues or organs, that's T4B. You then have the Duke system. So instead of going to 1, 2, 3, 4, it's A, B, C, D. And then you have a description of the T and M staging and the corresponding Duke stage, which I think is important to know. Easy to remember. So A and D, two extremes. So A is just to the submucosa, so T1. Anything that's metastasized distally is D. And then if it is gone beyond the transmural part, so if it's crossed entirely, and if it has any lymph node involvement, that is going to be a C. If there's no lymph node involvement, that's a B. That's how I remember it. Cool. Now, when it comes to treatment, we always try to resect all possible primary tumors. If it's surgically possible to resect it. And the treatment is usually going to be a colectomy, where we resect a part of the bowel. And this is often going to be with the regional lymph nodes, just to make sure that we get any lymph nodes that might have had metastatic spread to. The degree and the part of the bowel that's removed depends on where and how large the mass is. So right-sided tumors that affect only the ascending colon without the hepatic flexure. So this is the hepatic flexure. So anything that's, let's say, here and below, so let's say if it's tumors here or here, we would undergo a right hemicolectomy. And we take out everything up to this point. If you have a right tumor that is extending to the hepatic flexure, You then go for an extended right hemicolectomy. So you go for the entire right side and also most of the transverse colon. You then have a transverse colectomy with smack bang in the middle. For left-sided tumors, you undergo a left hemicolectomy, and same logic. If it affects the splenic flexure, you go for an extended left hemicolectomy. Colectomy, yes. And if it affects the sigmoid colon, you can go for a sigmoid colectomy. What else is important to know? I think that's all. And then finally, in terms of a medical approach, you can always consider adjuvant chemo and radiotherapy. This is going to be my stock standard response for every cancer we talk about. But specifically, there are a few newer biological agents like anti-VEGF or vascular endothelial growth factor, like bevacizumab, yes, and that's a monoclonal antibody, and then the EGFR antibody, cetuximab, which can be used and which I will never be prescribing probably in my life. But again, important to know. I mean, no, sorry, not important to know, just important to know that there are biologics present. Okay, some important stuff that no one talks about, but I think is really important, and I only learned last year on my GP rotation. Fecal occult blood testing is a screening test. You only do FOBTs in asymptomatic patients. Do not suggest this investigation if someone presents with blood in their stools. You sound like a complete idiot. All FOBT does is tells you if there is some form of GI bleeding that may not be visually picked up. Right? So if there's bleeding, please don't order an FOBT. Also, this is only to be used in asymptomatic patients. If a patient comes into you with signs of an IDA or iron deficiency anemia, fatigue, lethargy, weight loss, change in bowel habits, and is above the age of 50, you do not do an FOBT. You send them straight off to a colonoscopy. CEA, or carcinoembryogenic antigen, is a good cancer marker that's colorectal cancer specific, but it's not used for diagnosis, but mostly for monitoring. So what we do is when we diagnose them, we measure their CEA, we treat them, and after surgery, we would measure their CEA and note how it's progressing. If you see a sudden rise in CEA, you worry about things like relapse. You can also get nosebleeds, surprisingly, that present with melena. So it's very important to distinguish between RESP and GI causes of bleeding when it comes to bleeding. Now, angiodysplasia, I talk about angiodysplasia a bit on our lecture on upper GI bleeds, but it's a very common, or it's a pretty common condition that's becoming a Monash favorite on examinations. So what is angiodysplasia? Angiodysplasia, angio meaning vessel, dysplasia meaning poorly organized, is basically a vascular abnormality that presents in the gut, right? It typically presents in the small bowel and can bleed very easily. So it can present with kind of an upper GI bleed kind of picture. So you can get melena, you can get weight loss, you can get IDA, everything that sounds cancery, but you don't pick it up on a colonoscopy because a colonoscopy only goes to the ileocecal valve. It doesn't actually go into much of the small intestine. And likely, a gastroscope also only goes to the duodenum. So this, which is commonly the jejunum or the ileum, is not going to be picked up either by a gastroscope or a colonoscope. That's important to know. And it's a bit of a sneaky bugger. And therefore, the imaging of choice is a CT angiogram. CT angiography. Why CT angiography? Well, because this is a vascular abnormality. If you give them contrast, you can actually see those abnormal vessels on a CT if it's with contrast. And therefore, that's the diagnostic imaging of choice. And this was an exam question for us, asking, or it had a picture that sounded like a cancer. Honestly, it sounded like cancer to me. So weight loss, IDA, they had melena, but then they did a colonoscopy that was normal, gastroscopy that was normal, and they asked us what the next best test of choice would be. And one of the answers was FOBT. So please don't be the person who says FOBT for that. And that's all we had for colorectal cancers. I hope that helped. Any questions, chuck me a message. And as always, please look after yourself and please look after your loved ones.